I'm going to share with you things that have cropped up over the last 4 days. I want to particularly talk about how I think the disease is spreading. I want to talk about some of the points that I'm picking up from public health experts, but also from politicians. And then, because this is the real rhythm that I want to get into with a new series of briefings, I want to focus on the issues that I am concentrating on right now before we go into the interactive session. Just to make a couple of remarks about who's around. Florence, who normally works with me here, is shifting on to other work, and very important work related to food and food systems. She's an agronomist, it's her area of specialism. And so very kindly, Catherine Deland is now working with me in the role that Florence has, and will be helping to make certain that I've got access to your information. I'm really grateful to Catherine for supporting. Just putting in here, I'm filling in the poll. Age range under 30. How am I feeling today? Oh, good, yeah, I've got the answer. Excellent, good. Thank you, Twee. Okay, so Twee's got all the things. She'll give us the poll in a minute. Twee, do you want to wait for a bit, or do you want to give us the results now?
We'll wait and we'll share it at half-time. I think people are still voting.
Thank you very much indeed. I'm just looking at the screen to see who's here, and just want to say what a joy it is to see Scott Knowles. I saw you just now. Yeah, there you are. Scott Knox, sorry. Joy to see you tuning in from Canada, reading a lot about some of the challenges that are being faced in Montreal. Thank you, very, very interesting. If you want to come in at all, please do so. Loy Rago, thank you for joining again. Marianne, welcome. Betty, hello. Annie, great. Rebecca, thank you for tuning in from Chile. Chris Lara, I think you're on. Shafkul Islam, thank you. NK, Seti, lovely to see you again. Calling in from New Delhi. Joe Simpson as well. Kathy Matthews, welcome. Great to see you. Iman Ahmed, thank you. Part of the South Sudan diaspora. Very much tuning in to South Sudan recently, so it's good to see you. Carlos and Veronica, thank you for coming in from Mexico. Lovely. Joe Nichols, thank you for joining from your place, living in Nairobi, but covering Somalia for the United Nations, and really giving very helpful feedback on what's going on in your region. Jane Badham, thank you for tuning in from South Africa. Lucy Robinson from Bampton near Whitney in the UK. And Lucy, thank you for really helping me to understand some of the challenges faced by people with different abilities in relation to COVID, a very important area. Kirsten Hawkins, thank you for being with us, as well as Jen Wilker and Ratib Besudo. Holly Wheeler, enjoyed very much reading all your material on leadership, and this is so important right now all over Europe as countries really deal with the hardest part of any outbreak, which is keeping the numbers low when they're already quite low. Charlie Zeng, thank you for joining. Dieter, great. Rojan, thanks again for being with us from Kathmandu. William, my brother William Nabarro, welcome. Sarah Phillips, welcome. Louisa, welcome as well. Tracy, welcome to you from Western Canada. Arnie, great that you're here. And Bridget Malawese and Godfrey Philemon, thanks again. All of you, you are so welcome. What we're dealing with, you know, as we move forward through this outbreak is this absolute importance of getting the narratives right, getting the networks properly built up, getting the leadership good, and recognizing we're in the midst of an enormous sense-making activity for around 7.8 billion people. And it's, I believe, within our power to influence this sense-making process so that it comes right. So let's look at the patterns of risk, disease, and response. I do think we are seeing overall in the world a plateauing of the number of cases reported to WHO. But it's not a plateauing saying that the number of cases is dropping. It's just that each week the numbers of new cases seems to be relatively similar, but it's an awful lot of new cases. I mean, we're talking here right now the numbers of new cases increasing by more than 1 million each week. And this is definitely an underestimate. And it just happens to be that that's the level that we're currently at, with still lots and lots of new cases being reported from the Americas, lots also from South Asia, particularly India and Bangladesh. The numbers are still coming in and slightly increasing in Europe. They're much smaller numbers, but they definitely are on the increase. The numbers are reducing in the reports from Africa, and also the numbers from the WHO Middle Eastern region are also reducing, but the numbers from the WHO East Asia region, that's the one that includes China and the Philippines, they are on the increase. So it's a bit of a mixed picture when you look at total numbers, but there's absolutely no hint at all that this is subsiding. It's just that the rate of increase is fortunately plateauing, but the numbers are still very high. And the numbers of people dying are also still very high, around 40,000 per week. Now, these numbers, again, are not increasing at quite the rate that we thought. And there is a slight suggestion that the overall infection fatality rate is a little bit lower in developing countries compared with Western Europe and the US. And that's thought to be primarily because of the difference in the age range in the population, but there may be other factors to do with perhaps there being cross-reaction with other coronaviruses. And we talked about this a bit last time, so I've done a bit more work on it, and I'm very, very keen not to imply that somehow developing countries are getting off lightly, because they're not. And if we particularly dig in and look at the who is getting affected and particularly who's dying, then there's an awful lot of health workers. It's a bit like what we had with Ebola, that health workers are super in the front line. I've talked a lot about what some people are calling long tail COVID. That's the 5% of people who get COVID and go on being ill for a long time. And I'm seeing articles about this in newspapers almost every day. I was reading the Journal of the UK Royal College of Physicians, really showing that this is now absolutely being recognised within the British Health Service as a major issue that requires the collective efforts of people working on mental health, people working on metabolic disease, people working on viral disease, people working on neurological disease, because it does seem as though this long tail COVID is a pathological process that can occur inside the central nervous system, inside the respiratory system, and indeed inside the vascular system. Those of you who've got long tail COVID, it's really, really important that you recognize that your problem is not a figment of your imagination. It is a real condition that is being identified more and more. And I believe that we need to do more work on this over time and not let anybody say, oh, well, this is just a trivial infection and you recover from it and you're fine. No, 1 in 20 seem to get a much more serious problem. It's not that I want to say gloomy stuff. Occasionally I get people writing to me after I've done an interview on the television or the like, and they say, you're so gloomy. I say, no, I want to be realistic. I want to be straight, and I want to be an optimist that we as humanity can get on top of this by holding it at bay. So I come to my 5 headings, and these are not different from the 5 headings last time. They're a bit more organized. Number 1, this overall pandemic is a series of outbreaks, lots and lots and lots of them, caused by a dangerous virus that is here to stay. It's being spread by people in all age groups, with information coming from WHO in their Manila office from Dr. Kasai, the regional director, saying that in his view, this is being driven primarily by people in their 20s, 30s and 40s who are often without symptoms, but are still spreading the virus. So what Dr. Kasai is saying is that if we're going to help societies to deal with this series of outbreaks, that we do have to look at behavior of people in these younger age groups, as well as older people, and all of us have to recognize that we have a role in limiting the spread. Now, some are saying that the fact that the disease is being seen more and more in younger people is a sign that the outbreaks are changing. You know, is this a different kind of situation? It's the fact that we're seeing quite a lot of infections in people in their 20s, 30s and 40s, and that a lot of them don't know that they've got the infection. Is this a shift? Is the virus becoming milder? Has there been significant mutation? Well, there are reports that there's been a significant mutation in Malaysia, and that this Malaysian mutation is milder in that it doesn't kill so many people, and that perhaps this is what's happening. So then folk are saying, well, is this mutation going to make it so that the antibody and the vaccines under development won't work? Now, most people reckon that the mutation, the Malaysian mutation, is not going to mean that the vaccine development work all has to go back to square one. And my own view is it's too early to say the virus is weakening. We just have to say that yes, viruses mutate. Yes, it's an evolutionary advantage for the virus to become less lethal. That's always been the case for viral diseases. And so we just need to note that Dr. Kasai, who leads the Manila office for WHO, has reported that mutation is occurring based on the Malaysia data, and that this may be associated with more asymptomatic transmission. And yes, asymptomatic transmission makes handling outbreaks of the disease particularly difficult, and we have to put more emphasis on what we do in our personal lives to reduce the risk of transmission, because we may not be able to identify who's got disease just on the basis of their symptoms. Actually, a lot of the stuff about mutation, the mutation has come from Paul Tambiar, who's a consultant at the National University of Singapore and who's president-elect of the International Society for Infectious Diseases. There's apparently a name for the mutation, D614G. It's interesting that he's not the only guy who's talking about mutations. And I think this will become a hot subject for conversation with people who are just trying to work out what it actually means. More infectious, less lethal. I must say, when I hear about that, I think, you know, a mutation that is more infectious and less lethal does have a selective advantage. I want to go on about a little bit about how we conceptualize it. All under my first heading. I did say a series of outbreaks caused by a dangerous virus. Please don't lose sight of the dangers. The whole thing about not knowing very much about the virus, not knowing about its immunology, not knowing about what it's doing to people, does mean that, you know, when in doubt, perceive something as dangerous, even if it's getting mild through mutations, because otherwise we'll get caught. I must say that, as I say, keep with my first heading about the sort of general picture. I am saying that it's causing leaders everywhere to have to make really difficult decisions. They're difficult decisions because they require making trade-offs between different groups of people. And so as I go into my second heading, it brings me back to the strategic principles that I talked about last time that are at the center of what it is we're trying to do. And my colleague, Catherine, has been working with me a bit on trying to get the strategic principles into sort of quite precise language. And I just start at the top, what I call universal precautions. So strategic principle 1, everybody has got to adopt the precautions. And that does mean physical distancing, face masking, personal hygiene, both hand washing and cough etiquette, and then the discipline of being able to isolate ourselves when we think we are suffering from the disease. I think I want to really make a point about this, that the universal precautions have got to be done everywhere. And nobody is exempt. You know, we're not going to kind of bluster our way out of this. We're not going to get the virus to disappear because we present ourselves as strong men or strong women. It's nothing to do with that. This virus just has one objective, and that is to multiply. And this virus will multiply if we live in ways that make it easier for it to do so. So our universal precautions have to be about preventing this virus from getting the upper hand. And we're helped doing that by our second strategic principle, which is public health services matter. And here, I keep stressing that it's about being able to prevent the infection from spreading. Now, the fundamental way of doing this is through finding people with the disease, enabling them to isolate, tracing their contacts, enabling them to isolate, and supporting those who face particular challenges, and then suppressing outbreaks when they do start to build up. But I just got a request in a webinar just now with people from the UK Department for International Development. It was a great webinar with their health advisors. And one colleague said, well, what happens when you've got really intense community transmission? What happens if you're so busy you can't do your contact tracing? So I said, well, we had that before with Ebola at its intense time. At least isolate the people with the disease. You know, that's what you just must do. You don't want people with the disease being able to move around and infect others. Isolate them. Okay, so you may not have time to be able to get to all the contacts, but at least isolate the people with the disease and make certain that they really are isolated and reduce the likelihood that the disease can spread. At least you can then bring the numbers down, and you'll obviously introduce where you've got high prevalence, some degree of movement restrictions. I mean, you have to do that, but you really want to do your best to isolate people with the disease. And if you can't isolate individuals, you isolate, as I say, the communities that are affected, because that is the secret to getting on top of this. It's unfortunately really the traditional approach to dealing with infectious disease. If you look at history of infections, the fundamental approach to dealing with infectious disease was always to isolate people with the disease, to treat them, support them, but to keep them away from others. And that's what was the origin of terms like quarantine. It was really keeping people separate. And all our experience working in different parts of the world with infection has always been that traditionally societies know about this, and they know that people who've got infection have to be kept apart from others. And public health's about doing that, but doing it really well and doing it in ways that take account of some of the challenges that poorer people face when they're being asked to isolate. That it's not easy. So there's a very strong supportive function in there. The third strategic principle is just get integrated, but get integrated at local level. I've just been very much focusing on these outbreaks in food, and I was looking at what was happening in Melton Mowbray in the UK. I've also been looking at some of the other food outbreaks, not just in the UK, but in Europe and then in Australia. And I think what we're learning more and more with the factory outbreaks is that you've got to bring together everybody, the unions, so that they can help with the workers, management, and then local places of worship, churches or mosques or temples, and then community organizations, because there's a lot of fraternity and sorority organizations working often around big factories, and then residential care institutions, because people have got elderly relatives and sometimes they're being visited, so you've got to keep them involved. And then the hospital, and then public transport, the taxi companies and the local private hire companies. And then going beyond that, universities and the schools. Don't treat schools as separate from the local community. They're part of local communities. Bring everybody together. And we've been talking about the future of testing and tracing and isolating, and just recognizing these things don't operate in some kind of little silo. They are part of integrated local level action. And yeah, of course, there's tricky politics in this. Are the local MPs going to be very, very angry, or are they going to be helpful? Are some of the local businesses going to fight against all the actions that have to be taken? Will there be stigma because there are people from particular ethnic groups or national origins involved in outbreaks? Well, all these things can be dealt with through integrated local level action. And then there's this very important part about healthcare. And I'm just going to keep saying it. David, why do you repeat yourself? Answer. All the important things in life need to be repeated. And we must never tire of repeating them. And one of those is keeping essential health care going is key. Women are having children. Women need reproductive health care. Women need abortions. Women and men need care for long-term non-communicable diseases. Children need services, need immunization, treatment for their problems. People who've got cancers need care. People who've got injuries need to be able to get treatment for them. People with mental illness must get help. And a lot of people have got much worse mental illness as a result of this COVID. So let's keep essential health services going despite COVID, because COVID is here to stay. So we have to be clever and find ways to keep all aspects. I'm not just talking about medical services or nursing services. I'm talking about occupational health, physical therapy. I'm talking about all other services allied to healthcare, like pharmaceutical care, pharmaceutical services. So let's keep all these aspects going, and let's also give priority to the people who are providing care, making certain that they are properly protected with everything from plexiglass through to good ventilation, through to adequate face protection, and also being able to stay away if they're sick. Communication must be clear, must be consistent, and must be honest. Nobody wants communication from people who are essentially trying to provide nice stories for headlines or good news because they're worried that people are getting too much bad news. People want honesty more than ever now. They want to be told, is it likely that I am going to be able to see my elderly relatives? Under what circumstances? Is it likely that I'm going to have to cancel my holiday in 4 weeks' time? Is it likely that we're going to be able to hold a celebration for my mum's 80th birthday? All this kind of stuff is important, and it applies to all of us. We all have social lives. We all have important work issues to deal with. We all have family stuff to deal with. And so getting clear and consistent communication and not having two different leaders present diametrically opposed messages because they're politically opposed to each other or similar things, that's really going to be necessary to stop. And we're seeing still too much inconsistency, too many people making political points out of their communications. And then really, really important to have clear demonstrations of the performance of our COVID responses. And I am now going further with what I call the 7-point performance dashboard of the different things that are important, which includes support for people who are actually keeping out of the way because they've got symptoms. So these 7 strategic principles of universal precautions, public health services, integrated local action, essential health and other services, making sure that all who provide care are looked after, communicating clearly and consistency, and demonstrating the performance of responses with the performance indicators and the dashboards becomes really important. Now, within the work that we're doing, I've said we must put the interests of people at the centre, the interests of poor people at the centre, and the interests of countries within which there's a lot of poverty have got to be at the centre. And yet, leaders everywhere seem to be quite lost. So, what are the sort of steps that I think might be helpful right now? Perhaps we should be looking at the elements of a global campaign that all of us can sign on to, that all of us can support. Because we need to reposition ourselves to get ahead of this virus everywhere. What might that global campaign consist of? 1, universal precautions. All of us doing it everywhere. Not forever, but for now, while we get on top of it. Why not? Why not have everybody wearing masks everywhere? Why not have everybody working on physical distancing everywhere? Why not have a really strong, universal and intense hygiene campaign everywhere? And secondly, I think the campaign should be very clear on public health for all, really stressing that it's community-based and locally adapted, but it's getting that labyrinth of health coverage right throughout the community for all. Thirdly, essential health services for all. The things that matter to everybody have got to be functioning. It's no good giving up on reproductive health services or cancer care. Fourth, prioritising the needs of poor people everywhere. You can't do COVID without taking poverty seriously. And then making sure, fifth, that it is possible for people to access diagnostics, treatments, vaccines, and protective equipment. So let's get equity into supplies and into discovery. And lastly, let's have clear dashboards that show the performance of the responses. I talk about it as a campaign because I actually think it needs to be a movement. But, you know, movements evolve, but to stimulate movements and to plant the seeds, time for a campaign, I think. And so I've become a bit of an advocate for that. And I would be very, very interested to know whether you agree with me that this is the direction to go. You've been writing comments in the chat. I'm so pleased. I'd first of all like to go to Twee, and I'd like Twee to just give us the results of the poll and any other observations that you've got to go. And then I'm going to invite people to come in. Kathy, I'd love you to come in. Godfrey, I'd like you to come in. Bridget, if you're in, I'd like to get you. That's Bridget Malawi. There are also other colleagues from Malawi. And so if we can, that would be great. And then I'm going to invite members of our team to speak. Certainly John, if you want to say a word, Catherine, William, please don't hesitate to get my attention. Over to you, Twee.
For the poll results, I will actually hand it over to John because he can see that on his screen, and I've had a technical issue with the poll on my side. But other than that, just a quick response to Loy's message from last time as well around having more organised, continued conversations from this group. I really like that idea, and some of you will have seen we've activated the comment section on our website, as well as some subgroups already forming directly between people. I know put one on sexual and reproductive health and rights. And I'm thinking, if you have some ideas of other ways you've continued conversations with people that have worked for you, please do put them in the chat, and then we may look at running a poll, perhaps in one of the future briefings to find out what would work for all of you. Thank you.
Okay, so David, I'll pick up on the poll results. And this time, as you know, as might be expected from the time of day, people are, less people perhaps from Asia, but people from Africa, great to see you. Probably the largest single group is Europe, but also a good spread through the Americas, Latin America, Caribbean, North America, and probably a more even distribution of people than we've had so far in that respect. Less focused on one particular place. And the same's true also with the age range. Although the majority sits in 41 to 50, the 2/3 of us are between 30 and 60, and great to see some people under 30 here, as well as the over 71s as well. And in terms of how we're feeling, quite a spread, more positive than otherwise, a fair bit of optimism and hopefulness, but also there is some insecurity and powerlessness, discouragement, and doubt around. And this mix of emotion we're seeing a lot in conversations, and people move from one to the other and hold both at the same time. So that's the sort of picture of it, David.
Thank you, John. Now, I hope that colleagues will really get our attention. But Kathy Matthews, you're with members of the family again. It's lovely to see you all. I feel we're so close as we remember how we got together last year. So Kathy, over to you and the girls as well.
Thank you very much, Dr. Nabarro, and Caitlin and Lauren send their best too. And our question relates to young people today, calling in from Toronto, Canada, where the girls, among other Canadian youth, have a choice of returning to high school or continuing with the virtual program. And like so many other people around the world, the challenge we face is, if the children go to school, are they then able to see grandparents and the risk that they would bring? And so we're faced with the choice of going to school in person and not seeing grandparents other than outside, or not going to school and doing virtual and seeing grandparents. Yeah. I'm just wondering what your risk assessment is of that, and your opinion of the risks around that.
Yeah, thank you very much indeed. Now, all these issues around school are really personal for parents as well as for the individual children. And so any comment I make now is my general thinking, and I know that everybody on this call and anybody who's viewing any subsequent recordings will realize that really every situation has to be dealt with using as much local information and background as possible. Secondly, I do want to be clear, Kathy, there are unknowns about school. I mean, you know, and because I'm sure you've read it all, and certainly I'm sure the girls have, that it does appear that COVID is much less severe in the young and not at all severe in the very young. And so there does seem to be a general view that the children can go to school and be exposed to COVID without really major challenges. There are rare cases of severe illness, but they are pretty rare. But then the question is, okay, so I've gone to school and I got my COVID and I'm not feeling ill, but I know I got the virus. Can I go home? And can I be close to grandparents in their 70s or 80s? And am I going to give them the COVID? Well, there's not many examples of where it's been proven that a child brought the virus home, the grandparents got ill and subsequently had a bad time, but it is most definitely a possibility. And that's why the problem that Kathy has just identified, a bit starkly, is there, that the parents are saying, well, if they go back to school, then we have to shield the grandparents. And that means that the children and grandparents can't be close together. Well, I think that's wise. My own view is that If the numbers are really, really low in a community, then the risk that the child will bring the virus home is small, and one might choose to accept that risk. But if the numbers are significant in a community, and certainly if they're climbing, then it's more worrisome. And I think that the shielding ought to occur. And I believe that children should be maintaining the 2 meters distance, and there ought to be mask wearing around the grandparents. So that's in your comment in the chat, I think you said physical distancing and masks all day. But you also were referring to what's done in the school. And I actually think you're right that in school, there ought to be care to try to reduce transmission, which does mean getting class sizes to a point where physical distancing is possible, making sure that there are bubbles of the students so that if students do come close together, that they are pretty consistent and that care is done to make certain that the exposure risks are the same for everybody in the bubble. And again, I think children ought to be masking as well as parents. I don't think there's anything wrong with that. I think we're seeing more and more evidence that adults in the school environment need to be really careful and do physical distancing at the school gate, physical distancing in the staff common room and the like. And also that if there are any events at the school, that again, there needs to be careful precautions. And I think that a school should be, last point now, a school should be considered in its local context. So if there's a spike building up or a surge of cases in a local community, it is reasonable for the authorities to say that they would like the school to be closed or to go into some other particular disposition, such as, for example, much lower participation in the school processes or whatever. But it's reasonable that authorities should say to a school, you know, we've got an issue in the local area. We need you to do something, even if it's inconvenient for the parents. This is right. And my colleague Mike Ryan here at the WHO Emergencies Department is very clear. Don't treat schools as apart from the local community. Kathy, a long-winded answer, but because it's so important. And we were talking about it after one of the briefings last week, and we said we've got to be ready to come back to schools at regular intervals. So, Kathy, if you've got any comment on schools related to what I've just said, please come in now. And if the girls would like to speak as well, that's fine too.
Thank you very much, David. That's very helpful and consistent with what we have been thinking. And I guess it really comes down to, as we head into winter in our climate, you know, indoor visits with grandparents with masks and physical distancing, is that enough?
And it's hard to say. I mean, we, you know, there may be settings where it's not enough, and we've got to be even more careful. But right now, that's what we do. And certainly with my own family and others that I'm with, that's what I'm doing. You know, I have to be a bit cautious about myself, and I'm working on the assumption that masking and physical distancing is okay. Now, I saw you've also got points. Sorry, I saw that Tracy's got some points as well. So Kathy, if we move on now, if you want to come back in, please don't hesitate, but also please stay in touch if you have things that crop up, and I will try to keep also connected to you. Is that okay, Kathy?
Thank you very much, Dr. Nabarro.
Thank you. Now we go to Tracy. Tracy, if you want to come in now, you were going to make a point. I think you're in Vancouver, so we're a bit Canadian so far, and we will stay Canadian for a bit.
Well, thank you very much, David. Yeah, the children going back to school is a real concern for teachers and parents, and mainly because the teachers have not had sufficient time for planning and putting precautions in place and studying how they can keep children safe and give them a good in-class experience. So they would like schools delayed. And, I think it would be a good idea, because if they do get sick because the preparations haven't been put in place, then the schools are going to be closed for another period of time. So one of our public health officer, Dr. Bonnie Henry, has stated that children must wear masks in schools in high traffic areas such as hallways and lining up for lunch programs and on school buses. There is an exception, however, for children who are unable for health reasons to wear masks. So those children would certainly be at risk. So there's a lot of planning that needs to be done before the children go back to school. And, I'm a grandparent, so I worry about being able to see my grandchildren, but I want them to have their social interaction with their friends at school. Yeah. So it's definitely something that we need to give some serious thought to, and allow the time to give that thought some serious consideration.
I certainly agree that time is necessary, Tracy, but I do think we will also need to do some degree. More counter programming from the president, while Democrats have the nation's attention. We'll need to do some learning while doing, and but I agree with you that if at all possible, there needs to be sufficient time for teachers to be able to become confident that what they're being asked to do is workable. In my family, I have a brother-in-law who's a head teacher, and I must say I've been really impressed by the care that the teachers have been taking in his school to establish everything from the kind of route maps for where children will move and how they will move, and then the arrangements in different locations. So I think the more that we can hear from teachers about what they're doing and how they're doing it, the better. And Tracy, I'll keep in touch with you on this. Thank you very much indeed. I was going to ask Bridget to come in. Now, Bridget is Bridget Malawi. She's in Malawi. And Bridget, I'm looking for where you are.
I'm here.
I've seen you. Yeah. Hello, Bridget. How do you do?
I'm fine.
I know that you are country director for Seed Global Health. And I know that you've got a few things to say. And I also know that we've got Tita on, who also is from Malawi. So why don't you start, Bridget, and just give us your points.
Sure, thank you. And greetings to everyone from Malawi. So yeah, I think that for ourselves in Malawi, we're grappling with a number of sort of similar situation as others have raised. Certainly we saw a spike in the last 6 to 8 weeks. I think the beginning of July, we were seeing a real rapid rise in our caseload. And so, you know, a lot of the measures we've been trying to find a way in which we can contain cases in the country. Data is hard to find. You know, certainly we're getting a little bit of data and our surveillance is improving, but, you know, challenges with testing in country, challenges in contact tracing, challenges in maintaining people in isolation and even quarantine. So a lot of challenges in the past few months. And although I think these last 2 weeks, we're seeing a decline in caseload. And so there's conversations around reopening of schools in September, reopening of airports. And I think in the past week, we had our government try and gazette or sort of put in some regulations to contain public gatherings and other measures, and even implement mandatory mask wearing. And the issue that we've seen so far is that the measures as proposed from a public health perspective make sense, sort of in line with all these things, socially distance, wear masks. The implementation is really, really hard, and the acceptance from the public really challenging. You know, and I think they raise pertinent points. 85% of our population is, living on a day-to-day income. How do you ask them to socially distance and stay at home when they lose their source of income as soon as they stay home? They can't afford even, like, for example, $1 for a mask. Where are they going to get enough masks to clean them and wash them? Real challenges with access to water and soap. So just a lot of challenges that have made it really difficult for implementation. And we've seen the government sort of reverse some of their guidelines, which from a public health perspective is challenging because we believe in the measures, but I think it's how to implement the measures when it's obvious that there's not really how to really balance it from a contextual thing, how to make it contextual for the country when data is so minimal. And so I think those questions relate.
So tough. There is no simple solution to any of these problems. If the data are not very comprehensive, then knowing where the virus is really difficult. Physical distancing and mask wearing and hygiene, really hard to do if you're extremely poor. And those of us who've worked in situations where people can't get water and can't maintain the distance just get this. And so, Bridget, I suppose the really important thing that we all have to do is to understand just how tough it is and to know what are the things that we might do to be supportive. Now, you're very active on maternal women and child health. Is there any specific thing that you would ask of us, those of us who are connected into institutions, perhaps in Europe or North America or elsewhere? Any big ask?
I think currently it's how to manage the two things that we're seeing from a maternal, neonatal, and child health perspective. One is managing COVID in pregnant women and how to really provide. We've developed the guidelines locally, but certainly how to make sure that people feel comfortable and confident enough to manage it and have the facilities and infrastructure to do so. So that's sort of a general specific to COVID. The other is just really how to maintain service delivery. We're seeing already in Malawi, our immunization rates are dropping. Malawi used to have one of the highest, and we're seeing them start to drop. People are scared to come to facilities and services are being reduced. Even like reproductive, like family planning and other measures. So I think just the thought about how to keep these services going when you have so few staff, and how to think the planning. I think the planning for these services is what's challenging right now. Yeah.
So there you go. Thank you very much indeed, Bridget. Let me go to Godfrey in Tanzania. Godfrey, just if you, a bit short this time because I've not been so good with time control as I'd like to be. Just if you can do it in a minute, what are you seeing in Tanzania in as much as you feel you can say?
Okay. Thank you, David, and thank you the entire for social development team for returning this series for the Open Online brief on COVID. And thanks for the various participants who have been sharing your views since the outbreak. In Tanzania, the situation COVID-19 is very low. And no records of cases of COVID-19 released by the government so far. So the government is reopening all socio-economic activity, such as sports, entertainment, etc. And all restrictions related to COVID-19 have been removed. Public gathering are allowed, however, people are encouraged to adhere to social distancing, hand washing, and people have continued to protect themselves and especially focus on hygiene and hand washing.
Good.
So the government has also continued to open its borders and especially attract various sectors to return to its normal state. For example, Tanzania have witnessed the influx of thousands of tourists coming across the whole continent to visit national parks and the tourist areas in Tanzania. So the domestic trade has been reopened and it is increasing. However, foreign exchange between countries is still low. Taking an example, trades between Tanzania and neighboring country is slowing down. The trade is going on with the restriction of COVID-19.
Yeah.
And talking on the health sector in Tanzania, I myself continue to see what needs to be supported and developed as Tanzania continue to ensure political leadership that emphasizes investing more and investing better on healthcare services, especially on health infrastructure, medical supply, and health workers. According to the government data from 2015 and 2020, 1,198 dispensary, 884 health centers, 71 district hospital, 10 regional and 5 zonal referral hospitals have been built. This very successful action, of course, by His Excellency Mr. President John Pombe Magufuli.
Okay.
So this is a good job, well done.
Good. Thank you.
However, sorry.
Yeah, stop.
However, because now the country will need to recruit more health workers, and with the available resource and global economic crisis, the government and the other stakeholders should keep improving the knowledge of community health workers, especially on social determinants of health. Right. Community health workers who are properly trained, equipped, and supported can take on a range of tasks and otherwise depend on mid-level health workers. Therefore, the country continue progressing toward achieving universal health coverage by 2030. It would be a better decision investing in community health workers, women, and young people, because they are the key to delivering high quality health services for especially in the pandemic. That's it the most. Thank you.
Thank you, Godfrey. Let me just say, Chris Lara and Iman Ahmed provided feedback on the strategic principles the 7 strategic principles and the idea of a campaign. And there was a particular comment that we've got to keep the vaccine work up high. And I'd just like to thank you both, Chris and Iman. Iman, thank you for your observations on how remote techniques for accessing goods are becoming more and more popular in Canada. You've returned to Canada from Cairo, and it's interesting to see just what you've picked up. Lots of robotic shopper solutions and drone delivery and that sort of stuff. Thank you very much indeed. Joshua Knowles, would you like to show us your beautiful artwork and tell us what it is that's particularly interested you in this briefing?
Hi, yes. Hi, David. Can you hear me okay?
Yes, very well. Thank you.
Oh, great. Well, it's been very interesting to hear you speak. I've been struggling to keep up, to be honest. There's so much interesting detail there. I'm just getting the bullet points, and I'm going to try and get the drawing in as I go. So there's not that many pictures, but there's lots of captions that I've caught. The main things that I'm finding interesting are the new cases, the plateauing of the figures, but the cases are still high. That really stood out to me, and the idea of protecting health workers and also protecting all kinds of workers. That really seems to be the key message that's coming through to me today. And hearing about your campaign and the idea of starting a movement, that's really jumping out at me. Thank
you very much, Joshua. It's lovely. And I see that there's some bits missing. Between us how to reach you, and I will send you a little thing that will help you fill in the gaps, because I think this is going to be a great one, but we need to give you more help. Thank you, Joshua.
Thank you. That would be great. Thanks, David.
Twee, if you'd like to just do some sign-off remarks, over to you.
I just thank you everyone today. We've gone a little bit over time, but as usual, you can find the recording within the next 24 to 48 hours on our website, 4sd.info. And any other comments you have or feedback you have about this, you're always welcome to email me at thuy@4sd.info. Thank you.
Thank you, Twee. I have been developing a narrative which describes the different things we've been talking about, but one of the reasons why I've been talking about it today, so I wanted to get some feedback. And so it's not yet ready, but I am going to send my notes to Joshua, and Twee will have them, and we will be putting the narratives that relate to these briefings on the website shortly after the briefing. So you'll get both the briefing itself for the being able to pick up on the words, and also you'll be able to get a written piece about it off the website a few days afterwards. This is all with a view to equipping you so that you can take whatever you want on and act on it. I'd like to acknowledge the brilliant work of our team that makes all that we do possible. But most of all, as we finish, I just want to really give credit to all of you. You give your time to join these sessions, you participate with us, you make comments very openly, you let me invite you to speak and then invite you not to speak. You become friends over the period, you connect with us through email, through WhatsApp, and we love seeing your faces. Let's stick together because we're a network, and between us, I believe we can all contribute to the campaign and the movement that's going to be necessary for our world to get ahead of this virus. Thanks again. When we'll be doing this next time at 7:30 European time on Friday morning this week. Friday morning, and that is really something, 21st, that is something that I'd very much like to invite you to join. And don't hesitate to send us in any remarks on how we can make this more interesting and useful for you. And with that, I say bye-bye, stay safe, stay healthy, and be strong, because it all depends on you. Bye-bye.